Mic check, mic check, mic check, mic check, mic check. Microphone check, 1, 2, 3. Mic check, mic check, mic check, mic check, 1, 2, 3. Mic check. Okay. Mic check, mic check. Microphone check, 1, 2, 3. Mic check. I was kind of.
Yes, can you hear me okay? It seems to be coming from all around. What do you think? Okay.
Okay, it's 5 o'clock, and so we will start now the second lecture for our 28th Winter Series on Aging, Lefeber Hughes Winter Series on Aging. And so I want to welcome you all to this lecture today. I'm your host, Elena Volpi, and as you know, this lecture series features nationally and internationally recognized investigators and researchers on aging and geriatrics. And the series honors the memory of Dr. Edward Lefeber and his daughter Nancy Lefeber Hughes. They were both highly respected physicians, professor of medicine at UTMB, and beloved primary care providers for many Galvestonians. And they really love to take care of older adults. After Dr. Edward Lefeber's death, family and friends endowed this lecture series in the City Center on Aging to honor his memory. And unfortunately, after last year's untimely death of Dr. Nancy Hughes, the family and friends further contributed to this endowment in our memory. So today, I have the distinct honor and privilege and pleasure of introducing a highly successful investigator and researcher and also a fabulous mentor in aging and geriatrics. He's also the founding director of the City Center on Aging, Dr. James Goodwin. So Dr. Goodwin graduated from Amherst College with a degree in psychology and then went on to get his medical degree at Harvard Medical School, where he was also the class vice president, the graduation speaker, and a member of the Aesculapian Society. He then trained for a couple of years at the NIH before completing his residency in internal medicine and fellowship in rheumatology at the University of New Mexico, where he also became a faculty, and later on, he became the division chief of gerontology. He then moved to University of Wisconsin as a professor, vice chairman, and division chief of geriatrics, and the director of the Geriatrics Institute. And then he came to UTMB in 1992 to become a professor in the Department of Internal Medicine, chief of the Division of Geriatrics. And then later on, he created the City Center on Aging, and also in the clinical side, he created the geriatrics service line and the ACE unit. So his research is characterized by two distinct and highly successful phases, somewhat like, Van Gogh color phases. The first period involved lab-based investigation on immunity and prostaglandin and inflammation. And then the second period, he just pivoted all the way around, and which is still ongoing and still highly successful, and it focused more on outcomes, medical effectiveness, and recovery from illness in older adults. So his research has been continuously funded by the NIH for more than 40 years, I think more than 45, something like that, and has generated more than 470 peer-reviewed papers, many of which in very high-impact journals, such as New England Journal of Medicine, JAMA, The Lancet, you name it, he's published there. And then he's also published about 140 review articles and editorials and 2 books. So his papers have been cited more than 47,000 times, and he has an H-index of 114, which is one of the highest in this institution. He has mentored many students, postdoctoral fellows, and faculty, including yours truly, and many that are attending this conference today. And then he has also, many of his mentees are now independent, successful researchers and leaders in aging and geriatrics. He has also served in many national committees and editorial boards. Most recently, he's been the deputy editor for the Journals of Gerontology Medical Sciences. And he is a fellow of the Gerontological Society of America and a member of the American Society for Clinical Investigation. He's one of the highest cited investigator, and in fact, he got an award. He got the highly cited investigator mentioned by the Institute of Scientific Information, and is listed as the best doctors of America since 1992. He's received also the UTMB Distinguished Faculty Research Award, and so please join me in welcoming Dr. Jim Goodwin.
Thank you, Elena. That was a very nice introduction. And thank all of you for attending today. I have a bummer of a topic, long-term care. It'll bring everyone down. Some will feel guilty about their mothers, but we'll just plow on. I mean, 2 or 3 years ago, I gave a talk called Last Gasps, How We Die. So this is going to be pretty good compared to that one. I've been doing research on long-term care, or essentially nursing homes, for 40 years. It's never been a focus. It's just something that's been sort of ongoing, an ongoing interest of mine. It started when I was at the University of New Mexico, and we started a nursing home service. And it was small. It was like we hired a nurse practitioner. We had about 100 patients in a couple of nursing homes that we followed. And then when I moved to University of Wisconsin, we built a bigger one. It was more like 400 and several different providers providing the care. And then when I did that, it was one of those, it was like in the 80s, and no one was studying nursing homes, so you could do just the simplest, most descriptive studies, and they were important. So we did a series of studies just on the complications that people living in nursing homes have. For example, if you've been in bed for 7 years, let's say absolute bed rest, which some people are, and then something like just turning you over to make the bed or something, you can break someone's arm or leg, and it's just a spontaneous fracture. Now, when it happens, no one thinks it's a spontaneous fracture. Someone thinks it's terrible abuse, but basically, that's what happens. I mean, that's the challenge of nursing homes, is the people in them can be so very, very old and so very frail. So it's obviously a big topic, and I will sort of, in fits and starts, hit various concepts of it. Does this go forward? Does that go backward? Do I go up or down? Maybe here. No, not there either.
Not going.
He's coming. He's coming. Huh? It should work. What a thing to say. That doesn't help me. All right. So here's the outline of what I'm going to talk about. What's long-term care? Who needs it? Types of long-term care, and then challenges with different models. The overall message is not so much that the system is broken, which has been in the newspapers a lot. The overall message for me is there is no system, but if we had a system, it would be broken. So what is long-term care? And this is from the National Institutes on Aging. It's a variety of services designed to meet a person's health or personal care needs when they can no longer perform those tasks. So when someone can't quite make it on their own, long-term care is coming in either as an institution, as a family, as neighbors, in the home, as paid caregivers, whatever, giving the support that's needed for people to continue to live as independently and autonomously as they possibly can. So it covers a wide spectrum. Let me give you a random example of long-term care. My godson Tulio. So my godson Tulio, he's 48, and he is autistic. He functions at about a fourth grade level in terms of not quite reading and things like that. But he lives in his own house in Albuquerque. And he has no sense of time, but he's just planning incessantly, just constantly planning with no sense of time. And so, I mean, the last call I got from him was 2 days ago, and we go out quite frequently, my wife and I. We're going to go out in April. We're going to go back in May for a couple of weeks. We're going in August. We're going in October. But he wanted to talk about Thanksgiving. And so we had this long conversation about where we would meet when we flew out 3 days before Thanksgiving. Would it be at the Frontier restaurant or would it be at this and thing? And he's not getting, anyway, so that's Tulio. He's very sweet. He's huge. He weighs close to 300 pounds, and he can, pick me and my wife up together. But he lives in his own house by himself with caregivers. And so the caregivers, someone comes in and pays his bills or helps him pay his bills, but essentially, writes the checks and pays his bills. Someone else takes him shopping. Someone comes in to remind him about, I think, what we call personal hygiene needs. Someone, reminds him and helps him with cleaning. And it's this whole array of people. And because of that, he can live happily ever after independently because he is happy. Very, very positive person, very, very, just a superb friend. He never forgets his friends. And so that's long-term care. That's just about the best long-term care can do. But it's an example. So in terms of the models of long-term care, there's care in care in the home by family, friends, or paid caregivers. That's what I just described, essentially, for Tulio. There's adult daycare, which I'm sure you're all familiar with. Assisted living, which grew a lot in the 1990s and early 2000s, and then sort of stopped. But it's still a very, very excellent alternative. And then there's long-term care nursing home. And there are things in between that you may think should be on that list. But those are sort of the big categories of long-term care. So I'll start at the bottom and, with nursing homes and work my way up. So the models of long-term care, what should happen is that depending on your need, that would dictate the model, once again, to preserve the most independence you can have. So there are people who need very high levels of care that are almost impossible to provide outside of a nursing home or similar institution. But the problem is that some people that have rather limited needs, they don't need a whole heck of a lot. Let's say someone like Tulio or someone who's even a little better off than Tulio can wind up in an institution for lack of alternatives and can actually get trapped there. And that's best described by a woman named Carabeth Laird. Has anyone heard of Carabeth? totality of nursing home care, not all nursing home care, but a big chunk of it, presented that to our faces where we had to look at it. So I'll get back to happy news soon, but this is a graph of the number of people who live in nursing homes by year. And over on the left side of the slide, it says 1954. And then each little stripe is another 5 or 10 years further on, until you finally get on the right side where at about 2010, it gives yearly data. But what you see on the slide is that over the 1960s and 70s, there was this massive increase in the number of people who lived in nursing homes. And this doesn't look like an audience participation type of group, so I'll just tell you. So, you know, there are several reasons for this. I mean, one is there was somewhat of a growth in older people, but not that big, and not in the age group which uses nursing homes, which is really mostly 85 and older. And then there was some sort of shrinking of multi-generational households, you know, which would also lead to maybe institutionalization. But the two biggest things that happened, anyone want to come up with? What? Medicaid. Good guess. You had it. So Medicaid in '66 funded long-term care. Well, whatever you fund is going to get used. So that really led to this huge increase. That was the pull, you know, that the government was going to fund it. The push was another big government act. So Medicaid was President Johnson, Lyndon Johnson, part of the Great Society in 1966. In 1963, President Kennedy had passed the Community Mental Health Act. And what the Community Mental Health Act did is essentially, within a 6 or 7 year period, shut down every state mental hospital in the country. And state mental hospitals used to be sort of as widespread as prisons, to which they were compared sometimes. But they were the way people got treated. And people, and there was a lot of abuses and all that. But then again, we now see what happens when you don't have any sort of residential care for mentally ill people too. And so there were very good things. They said, okay, we're going to move all this care to the community. But while they were shutting down all the state mental hospitals, they really didn't work so hard in terms of an infrastructure in the community for these chronically mentally ill individuals. And I used to volunteer when I was in college. It was like in the middle of Massachusetts, and there were 2 state mental hospitals. One was in Northampton, which is like 9 miles away, and one was in Belchertown, which was about 14 miles away. I used to go over to Northampton. And for a few months, I was, every week I'd be talking to this one guy who was probably, I mean, back then I thought everyone was old, but he was probably in his 40s or 50s. And he was a nice guy. He was a sweet man, and we had nice, pleasant talks, but he didn't seem real crazy to me. And so one day I spent the afternoon looking at his medical records, which were, you know, like this. And they wouldn't let people do that now, but back then, this was before we discovered ethics. And so you could go and look through medical records. And I found out that the reason he'd been put in the mental hospital at age 13 was for excessive masturbation. So I realized why I was friends with him. I mean, no, we had a lot in common. No, but so that got him in. And then once you're in, you don't get out, right? I mean, it would have been criminal to let him out, right, after 30 years living in an institution. He was kind of happy there. So that was the growth. Then at around 2000, that thing in the middle, it goes up and up and up, and then it goes blip down. That's around 2000, 2004. That's Oregon and Colorado and a couple of other states decided to aggressively implement alternatives to institutional nursing homes. And so they just said, okay, like Oregon, oh, it was draconian. They said 80% of our Medicaid money for long-term care is going to keeping people in the community. We're shutting down the nursing homes. And so that had this little, but most states didn't follow that, and so it stayed sort of on a plateau there, and then it dropped in 19, 21, and 22, 200,000 fewer people in nursing homes in 2021 than there were in 2019, and we all know why that was. This is the death rates, not the rates. This is all the number of people who died every month who lived in nursing homes from COVID. From the first line up on the left is 3 months together, March, April, May. And then every dot after that is just 1 month. So there were about 30,000 people in March, April, May, and then for the next 5 or 6 months it was somewhere around 5 to 10,000, and then it went back up, and then at the end of 2020, and then it went blam and stayed down. Okay, this compares that with the same type of graph, except those bars are the total death rate the deaths, sorry, not death rate, total deaths from COVID in the U.S. By everyone, not just people in nursing homes. And then there's a little black line down there, and that black line traces the nursing home deaths. So that's what we saw on the last slide, the nursing home deaths. So basically, in March, April, May of 2020, more than 100,000 people died of COVID that we all know. And then it fell, and then at the end of 2020, it went back up. But as opposed to the nursing home population, it went down and it stayed down, right? There's still some deaths, but it stayed down. It stayed down ever since the end of 2020. People in nursing homes weren't dying of COVID anymore, even though they were very frail. And that, of course, was because there was a very effective campaign. They were the first ones to get vaccine, both the workers at the nursing home and the residents. And then also, many of those people in the first year had COVID and survived, and so they had some sort of innate immunity. Whereas the rest of the country was not as did not have the same sort of adherence to vaccines, and so we've had several pandemic or several sort of surges since. One other irrelevant slide, but I'm kind of interested in it. This is the death rate, deaths per 100,000 by state. If you look at all the COVID deaths for 1920, 21, and 22. And I'm interested in this because I didn't know any of that. I mean, I knew that New York was the highest, and in New Jersey. And Florida is kind of high, but not as high as you'd expect, because Florida has such a high proportion of old people that you would expect a higher thing. Texas looks pretty good, huh? You don't normally see this type of thing for Texas, right? We're always 48th, and so Texas looks pretty good. And then some things just, I have no idea, like Michigan. Michigan is, among the highest death rates in the country. And you look right next door, Illinois, it's one of the lowest, right? Michigan's got Detroit, Illinois's got Chicago, Wisconsin's got Milwaukee. They all have big cities with concentrations of people. And so, and this we don't talk about, but any sort of COVID epidemiologist would agree, there was an enormous amount of randomness in this pandemic. And what happened is anytime something random happened here, whatever happened, one side or the other said, that's because of this, that's because you didn't do this, when basically just a lot of random stuff. But anyway, irrelevant to the underlying talk. So how does one wind up in a long-term care nursing home? And the traditional way of seeing a path to institutionalization is you do a study like Dr. Markides back there does, a big, long population-based study, and you get a lot of information on the people you're studying, and then you look over time who winds up in a long-term care nursing home. And so we know from those types of studies, and there are many, many, obviously the older you are is a huge risk. Being a woman is a big risk because women live 5 years longer than men. Having some impairment, disability is a risk. Dementia is a big risk. I said social isolation. What I really meant was social support. Certainly, marital status is protective, and living alone is a big risk for institutionalization. And then limited financial resources. But this is a study we did, I don't know, about 8 or 9 years ago, that shows that age sort of trumps everything else. And so in very old people, some of the other risk factors don't matter much. So on the left side of this is like one's risk for winding up in a nursing home. And I forget what the reference value here, but so if you're unmarried versus married. So the young old, the 66 to 70-year-old, not being married is actually a fairly large risk, 64% increased risk of winding up in a nursing home over the next few years. But when you're over 90, it's really not a risk at all, because 90 is sort of overwhelms that risk. Same with lots of different comorbidities. The middle one, where you have a lot of illnesses versus not any illnesses. When you're younger, that's a fairly substantial risk for winding up in a nursing home, having a lot of different illnesses. But in older, very old people in their 90s, it's not a risk. And then even with dementia, it's not as big a risk in 90-year-olds because age itself is the biggest risk. So I showed you the path to institutionalization that we always thought. This is a path that we came up with when we started studying the path about 10 years ago. And it's a little more complex. And so what happens in this path is you start in the community, but rather than going like in that slide I showed you where you go from the community to the nursing home, you go from the community and maybe you're getting a little frail. I'm going to begin to bump some people out again. So maybe you're getting a little frail. Maybe you notice that when the kids come home for Thanksgiving, they're always gathering in the kitchen talking about you. Sort of, what are we going to do about Mom? Stuff like that. My wife and I have decided that when we turn 80, we're going to brick up the kitchen. But and then, so you're hovering, right? And then something happens. And it's always something happens. You don't go from a kitchen conversation to the nursing home. You wait and something happens. Something happens is a hospitalization for anything, okay? You break your hip, you have pneumonia, whatever. And you wind up in a nursing home. And then, on the first day, some discharge planner comes around. I mean, you've just been gored by an ox. And on your way to the OR, the discharge planner is saying, well, do you know where you're going? I don't know if you've had to deal with discharge planners, but that's the reality. And they come around and start pushing that maybe you should go to a rehab facility after the hospitalization. And there's huge incentives for hospitals to do that. Because they get paid for the stay. And so if the stay is 3 days, they get paid the same as if the stay is 6 days. So there's huge incentive for them to get patients out early. And so you go to the acute care nursing facility, which is the same building as the long care nursing facility, except your care is reimbursed by Medicare rather than other things. And they pay for 21 days of rehab. And many people then go home and live happily ever after. but a substantial proportion never leave. They just stay. It's barely a decision. It just sort of, one day they're in long-term care, same bed, same room, and it's like what the nuns who taught me grade school called a sin of omission. You know, no one does anything to stop it, and so they wind up in long-term care. So when you're trying to convince your mom to go to the, little rehab facility after the hospital, and she's very stupidly resistant, she knows why she's resistant, because, that's the path. And that's not just speculation. I mean, in our studies, we found that 2/3 of all new admissions, in other words, people have been living in the community to long-term care, they went through that pathway. Hospitalized, then SNF, then switch over. And so while the intent of SNFs is to discharge patients home, many of their patients never leave, transferring instead to long-term care beds in the same nursing home. And the risk, this is very important, the risk that a patient winds up permanently institutionalized varies a lot depending on what hospital you're in, but mostly what SNF you go to, and I'll show you that data. In other words, some SNFs are very good at getting people back home in the community, and some are not good at all. So these are some of the data. When we first sort of came up with this model, we had about 12 years of Medicare data, several million people. This was with Dr. Youngfang Kuo and a couple of other people, where we looked at people's, once again, following hospitalization, what was their risk of winding up in long-term care. And as you can see, the older you get, the higher your risk of being in long-term care, going from 2% to 20%. As I said, the women are more likely to go. These numbers, these percentages are not adjusted for anything. Black individuals in this study were slightly higher, more likely to wind up in long-term care. Having a primary care physician was protective. So if you have a PCP and they know you, and they see you in the hospital, they may say, well, no, she can make it at home. I know her. Whereas if all the people who are taking care of you are strangers, and what Dr. Sharma and Kuo and I showed almost 20 years ago is the majority of people now, and it's gotten worse, the majority of people hospitalized in this country never see a physician they've seen before. Like when you go into the hospital, you're taken care of by people who don't know you. And so they're overly cautious, as they should be, and they make decisions like to be safe. And so this winds up. And then the other risk factors are the same. So the one at the bottom, transferred to a SNF, what that means is that if you're in the hospital and you're transferred home, or if you're transferred to a SNF, getting transferred to a SNF increases your risk of being in a nursing home 6 months later tenfold. That's a pretty line with red at both ends. So what that line with red at both ends show is that there's a huge variation among the 14,000 skilled nursing facilities in this country in how good they are at getting people home. And this just shows the characteristics of skilled nursing facilities that are associated with getting people home once they get there. And the ones I'd like to focus on are the two sets at the bottom of the page. The average RN staffing ranking and the total nursing hours per resident per day. What this shows is that nursing homes that have sort of more nurses per patient, per 100 patients or whatever, or more staff, more staffing hours that are actually working with the patient per day, have a much higher rate of discharge to the community at the end of their stay. These two things at the bottom go into what's called the CMS, the Center for Medicare and Medicaid Services nursing home ratings, which most people have never heard of. They're easily, all you have to do is Google nursing home rating, and it'll say something .gov, and you click on it, and you know, they'll give you the ratings for everyone in your county or in your area or whatever. And it goes from 1 to 5 stars. They fix it so that 20% have the highest rating, and then 20, 20, 20. So there's no Lake Wobegon where everyone's above average. They really spread out the nursing homes in terms of these very objective ratings of staffing and complaints and issues like that. Anyway, those are strongly associated with outcomes. In other words, if you're in a 4 or 5 star, you have a much higher chance of avoiding being rehospitalized, of being sent to the emergency room, and a much higher chance of returning to community. And so take-home message is pay attention to the CMS nursing home. You shouldn't go to a nursing home unless it has a 4 or 5 star rating. That's 40% of them, so you can find one. But it's a key thing in terms of the care you'll receive. This is a slightly more complex slide, which the message is the risk of winding up in a long-term care nursing home after going to a SNF varies a heck of a lot by state. So the top 8 or 9 on that list are the high states, and then the bottom 8 or 9 are the low-risk states. But the ones that at the top, South Dakota and Iowa, more than a quarter of the people who get transferred to skilled nursing facilities after hospitalization wind up in that nursing home 6 months later, and they're all from the community. I mean, so this is like a new institutionalization. Whereas the ones in red at the bottom, they're all like 10% or less. So a much lower risk. The things that these red states have in common is they're not necessarily red states, but they're not geographically in common or grouped. What they all is, they all share the attribute of spending a lot of their Medicaid money on alternatives to institutionalization. And so all of these states, Oregon led the way, but then other states seeing gradually, it took a while, but seeing this success have sort of jumped on board. So I won't spend much on this, but when you have a problem in an institution, you study it and you see the problem, like in a nursing home, and then you get authorities and you get on groups and consensus panels and all that, and then the consensus panel makes a whole series of recommendations. I used to be on these, and I just really got tired of it very early. Anyway, and then the recommendations then generated a series of rules. So the state would then make a bunch of rules saying, okay, well, you have to do this. You have to spend this amount of this, and you have to do this, and they have to be up here. But then the state also says you got to document those rules or you're going to be in non-compliance. And so then you have more people documenting the rules, which means you don't have as many people taking care of your patients. And so then you have an obvious problem with care again. And this is not just a silly little cynical thing. This is something that just about anyone, you talk to hospital administrators, nursing home administrators, the amount of regulations that come down that they have to devote their best trained people, the masters of social work, like in child abuse protection agencies. The masters of social work are the ones who are filling out all the forms, whereas lesser educated people or trained people are doing some of the actual client interactions. But it's true in hospitals, it's true in a lot of things. So the reason I'm bringing that up is not to be cynical, but to say when you're coming up with a solution, you have to understand all the cost. You can look at something and say, yes, this is terrible, but then you better make sure you know the costs of your solution. And so I'll talk about that a little more in the future. Andrea is not here, right? Good. Oh, no, she is. Okay. So I put this section in because Andrea, some of you know, is a nurse practitioner in geriatrics who just retired 2 days ago. or 3 days ago or whatever. I haven't gotten over it yet. And so this is a section on nurse practitioners and how important they are to nursing home care, and how the advent of the growth of nurse practitioners has allowed for like full-time people working in the nursing home all the time, which has really improved the care of people in nursing homes. Having said that, I'm going to skip all these slides. And so let me talk about other options then. So we got assisted living. We've got continuing care retirement communities. We have increased support for in-home care. And in many ways, the lack of federal mandates, on the one hand, sucks, because if they had some more, maybe they'd put some more dollars behind it. But on the other hand, it's good because it allows each state to come up with their own plans, and you can actually see, oh, this works and this doesn't. And so there's huge differences between states in how much money they outgo for nursing home care versus community-based alternatives. I mean, some of the states, it's 80% for nursing home care, some are 80% for community-based alternatives. So this is a very important and sad message. This is, what are the options for long-term care, depending on your socioeconomic status? And so the low income is bigger over there. That's because they actually have more options than the middle income. A low income, everyone has family caregivers, potential, but the low income has Medicaid long-term care. That can be either in the community, depending on what the state says, or in a nursing home. Low income housing, dual eligible for other benefits. High income has family caregivers, and they can afford private pay assisted living. They can afford paid caregivers in the house. The middle income, they're not eligible for Medicaid, and they can't afford the other options. And by middle income, I'm talking about $25,000 to $100,000 household income for like someone who's 80 years old, for a couple. Household income for a couple that's 80 years old. That's what I'm talking about, middle income. So I'm not talking about real wealthy, people. But they don't qualify for Medicaid. They can't afford the in-between options, and they're stuck. So what do? Many of you know this. They spend down. They go into a nursing home and spend their savings down to where they do qualify for Medicaid. And then they're trapped, right? They have no money left. And so this is a national scandal. It's one of those weird things, because we mostly focus, we're always focusing on poor people, because poor people often lack insurance and do this thing. But this is one of those things where the middle income people are the most disadvantaged when it comes to long-term care options. So here's long-term care insurance, which is an option, isn't as big an answer as we thought it was. For years, those of you who have ever done retirement planning, or even just making a will, they're going to tell you to get long-term care insurance. It's like flossing. It's like everyone's got to do it, when it was first developed, however, there were no data on it. There was. I remember in the 80s, and I was in Milwaukee, and these three guys, there's two guys and a woman, very well put together, all of them, came up from one of these massive insurance companies in Chicago to ask me how they could generate predictions of who was going to wind up in long-term care. Because when they give us life insurance, they know, they really know at a population level. They have just superb data on what your risk of dying is at any time. Something like COVID or nuclear war tends to screw it up a little bit, but it's basically doesn't get screwed up much. But for long-term care, they didn't, and so they used data. So like the stuff that Dr. Markides does and other people do with longitudinal studies, and came up with plans, and that's how they set their rates. and then 90% of them went broke. Because when you buy life insurance, that does not increase your incentive to die, okay? Even though someone will make money. But when you buy long-term care insurance, it increases your incentive to get long-term care, and so more people got it than they predicted. So now there are a lot of limits on the benefits. It's like $100 a day, and it's like 30,000 total. I mean, not, that's on average among those things. So it's not anywhere near as grand as it was when you may have heard about it 15 or 20 years ago. So assisted living, about 800,000 individuals live in assisted living scattered around the country. And it's interesting, these people, when you look at them, they don't look all that different from a lot of people in long-term care. The costs are lower than certainly private nursing homes, but comparable to what Medicaid would pay. Most of them have cognitive impairment. 40% have dementia. I mean, they're moderate to severe cognitive impairment. They're 84. That's about, nursing home age is a little higher than that. And they stay about 2 years, which is what also is true in nursing homes. So that's that's a really good option for people with means, but it would be much more used if things like Medicaid were expanded to broader income groups and would pay for it. Medicaid will, in some states, because it varies massively by state, but in some states, Medicaid will pay for assisted living. It makes sense to them. So, continuing care retirement communities are just sort of, I think you probably all know, but it's like you've got your independent living and you've got your assisted living, and then you got your nursing home, and maybe high end you got your graveyard or whatever, and it's all, and then the various packages depend on the service. In other words, you can get some where you pay a big upfront thing and you're pretty much guaranteed that your rates won't go up after that, or you can just pay as you go along. Let me finish by going through the long-term care in the home, though. That was back to Tullio. And there's two general types of state support for in-home care. There's the state send in caregivers and other services for set amounts of time. I think that's all Texas has, but I'm not absolutely sure. And then other states, New York notably, but a whole bunch of states now, give the family a budget. So there's, the family, they say, here's $2,000 a month. We're gonna notice where it goes, but you get to decide between these services. You get to pick between these services. And you can hire your family members to take care of this person, okay? So in states like New Mexico or New York and Florida and many other states, family members are paid to take care of people in their home with long-term care. And people say, oh my, that might lead to fraud or abuse. Yeah, but once again, think about the alternative, okay? So anyway, I'm a big fan. Unfortunately, it's limited to people who are eligible for Medicaid, and not all states have both of these programs. So the challenges of providing long-term care, it takes a village and there may not be one. Back to New Mexico, on this little road that we have our house on, it's a 3-mile dirt track, and there's about 10 houses along it. It's very isolated, very few people. And there's one, this is insensitive, but just crazy, crazy, crazy person living on it who has been in and out of institutions all her life, she'd never make it in town. Maybe now she would, she'd be in a homeless encampment, but basically she wouldn't have. But she lives on the road, and the other people on the road take care of her, okay? Because there's enough of them. There's 9 other houses, And so she needs to go into town to shop. Someone does this. And she never asks, so let's see her walking on the road. And she wears a beekeeper outfit. For the last 40 years, I've known her for 43 years. She wears a full beekeeper outfit every time she goes outside because she wants to keep her skin nice. And she's like 78, and she really has just about the nicest skin. Anyway, so it takes a village. Who coordinates? In Tullio's case, his mother does, and she's very capable. But it's tough to coordinate, and getting and figuring out who does what. And there's a potential for abuse. And then, burnout, burnout, burnout. That's just, many of you have experienced this. It's a very, well, many people during COVID have experienced it like at work, but I mean, in terms of family situations, it's a very difficult thing. So, I'm going to just describe the New York program because there was this outraged editorial in the Wall Street Journal about it. It turns out that New York Medicaid for home-based care is equal to all the other states combined. And the Wall Street Journal is quite outraged because they're paying, Lord knows, teenagers to help. And it is a very generous program because the caregiver can be anyone designated by the person who's in charge making those decisions. They receive a nice hourly rate, plus they get benefits. They get health benefits and vacation, stuff like that. So it's really quite nice. In terms of the abuse, if you Google, how to get on Medicaid, all the hits are going to be from New York, where you have to pay a lot of money, where people can help you, become Medicaid eligible. To get on this thing, because this is such an amazing benefit. And New York, to its credit, I would say very few things to New York's credit normally, but to its credit is expanding this program more to middle-income people as they go along. So it's a very nice program. So, there's this back and forth between controlling things and not controlling things, between socialism and whatever. Everyone hates Department of Motor Vehicles. Well, actually, Texas has gotten a little better in the last couple of years, but everyone still hates them. Monopolies do eliminate competition, stifle innovation, efficiency, accountability. Systems tend to lack flexibility. On the other hand, no one wants to eliminate the socialist programs we have. And hybrid systems where you have public funding but private implementation, like Medicare, can have massive administrative costs, overuse of services, and it can be all about maximizing revenue. So there's a trade-off. It's not like this is good and this is bad. A lot of countries like Sweden or Great Britain, and even in this country, we sort of go back and forth from over here to over here. We go over here and people are getting too much of this, and we then privatize this and go back. And so I think it has to be that way as opposed to this has to be the system. We have to sort of stay wise as we go forward. So final thoughts. Long-term care has been slowly improving, but it's still justifiably viewed as a broken system. And I don't think you'll find a lot of people nationally that disagree with that view. Even if it's just the middle income, which it isn't. I mean, it's also these huge variations between states where if you live in many states, you have very, very little option for home care. State and federal agencies might have to fight the temptation to over-regulate home-based care because people say, well, there's this, but then you come in with regulation and then people are going to be taking all their time regulating as opposed to care. And no matter what the system is, there's always going to be plenty of bad outcomes because people in long-term care are getting ready to die. The average length in long-term care is a couple of years, okay? That's the reality. These people are very old, very frail. And so bad things happen to very old, I'm bringing you down at last, very frail people. And finally, expanding state and federal support of long-term care to middle-income individuals should be a priority. Thank you.
Thank you very much, Jim. So now we have time for a couple of questions perhaps, and we have some in the chat that today is active. And if we have someone in the room who wants to ask a question, raise your hand. I'm going to have the microphone for you. We want to go for a chat? Let's go chat.
It says the decade of our 70s is absent from slide of risk factors and probability of living in nursing home. Why is that?
The
It's about
decade of
halfway
the,
through.
I think the decade of the 70s was the reference decade in that analysis. I mean, I sort of froze up when I got to that slide, but you know, when you do what are called multivariable analyses, you say, well, what's the effect of this factor once you control for all these other factors? And so when you do that, you have like a reference thing, and you're comparing them all against that. And so you can assume that the 70s results are somewhere between the 60s and the 80s results, but they weren't in that slide. And we can send slides out to anyone who's interested.
Questions from the audience? Here. Oh, okay. There's microphones on the
But
table.
you got to keep the finger on the on that thing.
Yeah.
Can you hear me?
Yes.
Yeah.
Okay, I used to work in an emergency room, and one of the factors that I found most helpful for placement was an advocate for the patient, whether it was their neighbor
Right.
or their teacher or someone that advocated. And
Right.
in your different categories, has anyone ever researched to say, in the Navy we used to call them ombudsmans, but someone that advocated for that patient?
Sure. I mean, I think that's what you're seeing when we talk about marital status or any social support. In most of the studies, you know, marital status is like the dominant provider of social support. But yeah, I mean, I shouldn't say a rule because I'm often breaking it, but I want the spouse in the room. All my patients are over 90, and I want the spouse in the room. I can't remember what the doctor tells me, you know. It's an emotional thing, and I can't remember what I was going to tell them. So you want the spouse in the room. You know, ombudsman sounds good, but then it's just another bureaucratic position, you know, as opposed to a daughter-in-law, which is a real thing. So, yeah, it is very important. And I would recommend everyone, especially guys who don't, but I'd recommend all the spouses or partners or whatever, you know, go with the guy to see the doc, because they're, you know, they don't tell docs anything.
That's true. That's true. One last question? Yes. Oh, go ahead.
Actually, I'm Dr. Gooden's mentee. So, great presentation. One question is regarding the regulation, because right now, nursing homes, they're highly regulated. The public reporting system has like 30-some indicators, quality indicators.
Yes.
So how can we move from reducing those indicators while maintaining the quality of care in nursing homes? What's your thought on that?
So I think that's one of those. I mean, I could draw a lot of sort of lines with arrows going all the way from here to here. You know, regulation, no regulation. And this is really bad, and this is really bad. And then it's like, then you try. You know, like I think that nursing homes now are overregulated. I mean, if they weren't, we wouldn't be able to do research on it, but provides us with all our data. But I think they're overregulated. They make people happy with their rules, but they're overregulated. They're taking people away from, they're taking the humanity out of it. They're taking the wisdom out of it. They're making everything structured. And anyway, so then you just got to try, right? And that's why I was saying, like, for countries like Sweden, you know, which was, and this is on a different spectrum, but like socialism to capitalism. You know, you try something because this, you know, whatever you have doesn't work, and so, you know, is working poorly, and so you try something over here, and that works better. But after 10 or 15 years, you say, well, you know, this is stifling this, let's move a little this way. So to me, it's a dynamic thing. It's not arguing about what the solution is. it's arguing for flexibility, continually looking and trying, and which is another nice thing about having 50 states. If you have a program that's different in all 50 states, we should be able to learn from that.
Thank you very much.
You're welcome.
The hour has passed, and so we can now enjoy a glass of wine, some food, which is right outside here. And thank you very much, Dr. Goodwin.
Thank you for that question.
I think the Medicaid spend down is really interesting.